Good morning. It's really an honor to be here, Dr. Foster. Thank you for organizing this fabulous meeting. It's also very nice to see many colleagues here, and it's an honor to be here for our patients, which is really the focus of this meeting. So as Antoine has just told us, birdshot is an uncommon disease, but is well characterized to date. It was initially described by Ryan and Malmany in 1980, and then subsequently by Gass in 1981. It's uncommon. In tertiary care centers where there are referrals for uveitis patients, it represents between 0.6 and 1.5% of uveitis patients in toto, or 6 to 7.9% of patients with posterior uveitis. The largest series reported to date comes from 14 centers in Europe, reported between 1980 and 1986, comprising 203 eyes of 102 patients. In the United States, Henderley identified only 7 out of 600 patients with birdshot, and in a more recent population-based study of patients in Northern California, only 1 patient by Greitz and Wong. The notion of birdshot as an emerging entity is reflected by the experience at the Massachusetts Eye and Ear Infirmary in caring for over 1,200 patients with uveitis, in which 19 patients were identified as having birdshot, or 7.9% of patients with posterior uveitis, making this the 5th most common diagnosis of that subcategory. In the subsequent 10 years, 35 patients were diagnosed and treated with birdshot at the same institution. As opposed to many other uveitic entities which occur at an earlier age, birdshot occurs at a mean age of 53 years of age. The shift to middle age really is, or the new middle age is unclear. The overwhelming majority of patients with birdshot are Caucasian of Northern European extraction, and is extremely rare among pigmented ethnicities. There appears to be a female predominance in a large meta-analysis, although there are some cohorts that do not bear out this predominance. While there is no definitive evidence for geographic clustering of birdshot, the number of cases reported from Holland, Belgium, and France have led some investigators to posit an infectious etiology. The paucity of reports from Asia and the Indian subcontinent is significant, and this may relate to the low prevalence of HLA-A29 in this population. Birdshot is thought to be a predominantly ocular disease that occurs in otherwise healthy patients with no definitive systemic associations. However, careful history and review of systems does reveal a fairly high incidence of cardiovascular disease, specifically systemic hypertension, which occurs between 20 and 46% of patients. However, this percentage and prevalence is similar to the lifetime prevalence in age-matched populations. It has been suggested that the presence of cardiovascular disease, specifically hypertension, may negatively impact the visual prognosis in patients with birdshot, although this has not been corroborated in more prospective studies. There are sporadic to systemic disease associations, including autoimmune centroneural hearing loss, myelodysplastic syndrome, sarcoidosis, psoriasis, vitiligo, and atopy. In the largest series that I quoted before, there was a very large prevalence of glaucoma, but this again has not been borne out in subsequent series. As Antoine mentioned, birdshot has the distinction of having the highest association of HLA in human disease, suggesting a role for immune dysregulation in a genetically predisposed patient. Indeed, up to 96% of patients with birdshot, of Caucasian patients, have HLA-A29 positivity, while this haplotype is present in 7% of the population. This confers significant risk for the development of disease. Perlman and associates have found a high incidence of systemic autoimmunity in white dot syndromes, to which birdshot is a member, and specifically in a quarter of the 16 patients they identified with birdshot, and in their first and second degree relatives. Familial forms of birdshot are distinctly uncommon. However, it has been described in monozygotic twins, and most recently in 5 families, 2 of each, with HLA-A29 positive birdshot. The A peculiar aspect of the epidemiology of birdshot is its essential restriction to the Caucasian population. Sequencing of the Class 1 region reveals over 20 HLA subtypes, the two most common of which are HLA A29.2 and HLA A29.1, the distribution and frequency of which varies with ethnicity. There are case reports of HLA A29. There are case reports of birdshot in the African American population and Hispanic population in the United States, and as well as Japan. However, the disease is extremely uncommon in the Asian population. The differential distribution of HLA A29 and HLA A29.2 and HLA A29.1 has been sought to explain the differential distribution of birdshot in the Caucasian population as opposed to the Asian population, with HLA A29.2 being much more frequent in the Caucasian population, thought to confer risk, whereas the HLA A29.1 haplotype occurs more commonly in the Asian population and has been invoked as having a resistance motif. The gene frequencies of HLA A29.2 in the United States among whites, African Americans, and Hispanics are fairly similar and are much lower in Asians. Certainly, the low prevalence of HLA A29.2 in the Asian population in the United States could explain the positive reports among this population. However, it does not among African Americans or Hispanics who appear to be strikingly protected from this disease. So there must be other factors that are operative here. Recently, both subtypes have been associated with birdshot on high-resolution DNA testing, and indeed case reports of HLA A29.1 in 2 white patients, which are identical to healthy Asian subjects. So it appears that HLA A29 is indeed associated with disease risk, however, irrespective of subtype. There must be unidentified genetic or acquired factors which are not linked to the major histocompatibility complex that are either protective in African American, Hispanic, or Asian patients, or conversely trigger autoimmune reactivity in white patients. This is especially true since the prevalence of birdshot among HLA A29 population remains low. Ralph Levinson has identified maybe one of these factors, killer cell immunoglobulin gene receptors, which are activating or inhibitory receptors for human NK and CD8 positive cells, which have been shown to confer significant risk for the development of birdshot in HLA A29 patients, while other compound genotypes have been shown to confer protection. It suggests these genes may be involved in the pathogenesis of birdshot by activation of NK cells and T cell subsets against intraocular self-antigens. The fact that the HLA A29 is present in up to 96% of patients with birdshot is indeed intriguing. However, this criteria, as we heard from Antoine, is neither necessary nor sufficient to make the diagnosis of birdshot. The positive predictive value of this test is actually less than 50% due to the low prevalence of birdshot among patients with posterior uveitis. So routine screening of patients with posterior uveitis would arrive at an incorrect diagnosis more often than not. The negative predictive value of this test is actually quite high at 99%, so that a negative test for HLA-A29 does have value in excluding the diagnosis of birdshot in patients in which an alternate diagnosis needs to be considered, such as these 2 patients with choroidal lymphoma and this patient that was referred to me with sarcoidosis that was phenotypically very similar to a patient with birdshot. Again, most of the testing that is performed on HLA testing has been performed with antibody testing. Recently, 2 reports of false negative HLA-A29 have been reported in the literature using PCR-based assays. So it is thought that the use of PCR-based assays may indeed eliminate some of these outliers. However, the question remains, are there cases of HLA-A29 negative birdshot retinochoroidopathy, and are there important differences in the prognosis and management of these patients? Indeed, the number of these cases is bound to be very, very small. However, the recent demonstration of differential cytokine production peripherally and in the eye may shed light on this issue. The natural history of birdshot is really unknown. There are some investigators who have suggested that birdshot may have a self-limiting course. In up to 20% of patients stabilize and go into remission over a 3 to 4 year period of time and maintain good vision, albeit with the presence of birdshot spots. However, at the present time, it is impossible to identify who these patients are. The overwhelming majority of clinical experience suggests a chronic, progressive course with multiple inflammatory exacerbations, marked by progressive visual loss and the development of structural complications, including central visual loss due to macular edema, and global retinal dysfunction as manifest by visual field loss and abnormalities of the ERG, despite, in some cases, good central vision. Both of these are a function of longer disease duration and appear to be independent of previous oral corticosteroid use. Indeed, few patients maintain good vision without treatment. Rathova and colleagues studied a large population of patients with birdshot and noted a very strong correlation between visual acuity at onset and the development of visual loss in time at 5 and 10 years. Visual acuity of less than 200 was found in 8% of patients at onset, 30% of patients at 5 years, and 39% of patients at 10 years. The most common reason for decreased visual loss in this series was macular edema and macular atrophy. It was interesting to note that if there was leakage in the macula based on fluorescein angiography at onset, that the visual prognosis at 5 years was much worse. In addition, in this group, the mean change in visual acuity or improvement in visual acuity did not change whether or not these patients were treated. However, it should be noted that in this series, they elected to treat patients with whose vision was 20/40 or worse and suggested that more aggressive treatment was necessary for birdshot. Thorne and colleagues have corroborated these findings, in which they studied 44 patients with birdshot over a 10-year period of time and found a 5-year cumulative incidence of 20% of patients of visual acuity of less than 2200. Visual acuity of less than 20/50ths and to a level of 2200s had a rate of developing at 13% per year and 4% per year, respectively. Both a longer duration of disease was associated with the increased development of structural complications and a poorer visual outcome. So given its uncertain natural history and visual prognosis, the general consensus has been the early introduction of steroid-sparing immunomodulatory therapy for the treatment of birdshot because of its inherent inflammatory effect, its steroid-sparing capacity, and the fact that extended treatment is necessary. The indices of active inflammation, rather than an arbitrary level of visual acuity, guide our treatment decisions. The clinical markers of inflammation may not always be apparent in patients with birdshot, and so inflammation as visualized on imaging modalities and also dysfunction globally of the retina as seen on electrophysiology and visual field testing help us in not only guiding treatment but in monitoring patients on treatment. The treatment goals is to alter this natural history of birdshot with the preservation of visual function, with the reduction of inflammation, reduction of macular edema, the preservation of global visual function, and the induction of long-term remission. Thank you.